How can cataract surgeons grapple with the subjectivity of patient vision after IOL implantation? Rayner's RayPRO platform for patient-reported outcomes helps to solve this conundrum. At Winter ESCRS 2024 in Frankfurt, they hosted a symposium showcasing the digital platform and how it combines with the company's RayOne EMV and EMV Toric IOLs to enhance the surgical experience. The results speak for themselves, and speakers from across Europe spoke on topics ranging from lens centration to an analysis of how RayOne EMV stacks up against the competition.
So we just had a really very exciting lunch symposium on the RayOne EMV. We heard about the Toric variant. Second talk was about a very exciting comparison between the RayOne EMV compared to a classical EDOF lens, the so-called Vivity from Alcon, with really very exciting data. At the end, we had a talk on RayPRO, where we learned what the patients feel about the surgery, not just only get the refractive results, but also the functional vision results.
So I've been using the EMV lens for just under 2 years, and what convinced me to use it? Well, I collected some of the first ever real-world outcomes in 2020, 2021. So for me, it was a natural choice because of the excellent patient satisfaction rates, the excellent quality of vision, the level of uncorrected distance visual acuity that you're able to achieve with the lens, and the very minimal dysphotopsia profile.
We started using the EMV lens in 2022, so it's like 2 years since we started it, and a little bit later on we started using the Toric version. And actually what convinced me was the use of optimal range of focusing the light and better quality of vision for the patients.
Well, it's a very interesting time at the moment to have these lenses available, to use non-diffractive lenses which offer a very good spectacle independence and do not have the downsides of all multifocal lenses which have low contrast sensitivity and dysphotic phenomena. So this is something we're all trying and very excited to use. So I spoke about the rotation stability of the EMV toric lens. The EMV toric lens is an enhanced monofocal lens with extended depth of vision. And on top of that, it corrects the toric angle, because you need to correct toric when you were aiming for spectacle independence. So we corrected above 0.75 and 1 diopter of astigmatism, and we had achieved really good results. We had 95% of the patients within 1 diopter of astigmatism and 81 patients within 0.5 diopters of astigmatism. As far as the lens goes, it was very stable. So we had very good centration. We had a centration of 0.2 millimeters, which is very good. And we had a follow-up of 1 week, 1 month, and 6 months, and it didn't change really between in this follow-up time. We had a tilt of 5 degrees, which is good. The normal cataract lens has a tilt of somewhere between 2 and even 10 degrees sometimes, so we're actually very good. So it didn't really change to the pre-op situation. So this lens has an anti-vaulting haptics, which have haptics which lock into each other like a jigsaw puzzle. So it doesn't rotate, it doesn't move, and it's got all features you need for an intraocular lens with a sharp edge against PCO and so on.
So my presentation was about the RayOne EMV lens versus the Vivity lens in a head-to-head retrospective trial. And that was looking at both the objective visual outcomes and the patient-reported outcome measures using the RayPRO software.
Both lenses actually performed really well, with over 70% of patients or eyes achieving within half a diopter of refractive spherical equivalent target, and almost all patients within 1 diopter, which is better than the UK benchmark.
We found in the Toric IOL group that there was excellent rotational stability in both lenses, and we found a little bit of an advantage with the EMV lens. So 61% of patients had less than 0.25 diopters of remaining cell versus 46% in the Vivity group. So the RayOne EMV Toric lens did perform slightly better. In terms of the visual outcomes, we found that the uncorrected distance visual acuity was statistically significantly better in the EMV group versus the Vivity group, and that was binocular visual acuity. That was in all groups, emmetropic aim, in groups with mini monovision aim, and in groups with moderate monovision aim. With regards to the near vision, we found that the Vivity lens outperformed the EMV lens by 1 line in both the emmetropic aim group and the mini monovision group.
So with a modest monovision up to -1 diopters with the EMV lens, you're able to achieve a similar level of uncorrected near visual acuity to the Vivity lens. but you're still maintaining that statistically significant superior uncorrected distance visual acuity. And that's a really interesting finding.
That being said, I always caveat that with the fact that with blended vision, you may need glasses in very demanding circumstances, such as driving on a dark, rainy road or reading in a dimly lit room. So as long as my patients are aware of that minority of incidences that they might need glasses, they're usually very happy with the outcome and spectacle independent 95% of the time. We found on our RayPRO questionnaire looking at patient satisfaction, we had a higher rate of satisfaction in the EMV group of 84% versus 78% in the Vivity group. So both very good lenses, both with very high patient satisfaction, but the EMV lens seemed to pip Vivity to the post.
So I discussed the patient-oriented clinic formation, so how to use the opinions of patients within the RayPRO system, so the system which is collecting the information from patients after the surgery. So RayPRO can help me in managing the clinic. For me as a medical director, it's very important to know the outcomes, but at the same time to compare between different types of lenses and see what are the long-term outcomes, including 1 year, 2 year, or 3 year results.
I was very interested to see this data because I'm both the user of EMV and Microsoft IQ Vivity. As you see, the numbers are really high. So in terms of the total responses, it's close to 5,000. The overall satisfaction rate is very similar in both Vivity and EMV group, and it's much better than the iHands group. So actually, you can see that the balance between EDOF and the monofocal lens with extended depth of focus is exactly the same level. And when you compare the distance, intermediate, and near values, they are not so differentiated between these two lenses.
When you start with EMV, you're more likely to tend towards symmetropia in both eyes, but the more you use it, then you're trying to use more offset. You're starting with micro monovision of 0.5 diopter, then you're pushing it up to 1 and 125 diopter, and even 1.5, which gives you true spectral independence, including near vision.
The RayPRO, I think this is a really exciting tool. It's a win-win situation for the doctor and the patient. The patient feels better cared for on the one hand. We get perfect results not only on the classic visual acuity but also on the functional vision. It's a great tool for advertisement, so we know about percentage of the patient satisfaction, which we can post in the internet.
Even with this symposium combining real-world clinical data on Rayner's RayOne EMV and EMV Toric with PROMs from RayPRO, there's a lot out there to discover about Rayner. For more insights, check out the educational content on Rayner's peer-to-peer channel.